Welcome to the Kazra Regional Hospital Bariatric Surgery Seminar video. I'm Dr. Aaron Guercio. Also in this video, you'll be seeing Dr. Dustin Porter. We're both board certified general surgeons. Dr. Porter trained at the University of Louisville in Kentucky as part of his residency, and then he completed his medical training at the University of Wisconsin. I completed my residency training in Denver, Colorado, as well as my medical school training there. And we've both been in this area now for almost 9 years, participating with general surgery and bariatrics. We have additional members of our bariatric team. You may interact with Tiffany, who is our coordinator in the clinic. We have Trey Pilster, who is a PA that assists us both with our surgeries as well as taking care of patients in the clinic and making sure their needs are met. You may also interact with DJ, who is our dietitian, who helps to prepare for life before surgery and life after surgery as well. As part of this video, we're going to talk about the various options that are available for bariatric surgery, how they work, what you can expect with them, and kind of how life is going to be like after the surgery is completed. Let's proceed with the presentation.
So we'll just kind of run through a couple of definitions of when we talk about bariatric surgery, so that occasionally some of these words are not part of your everyday language. So when we talk about bariatrics, we're talking about anything that is related to the treatment of obesity. And obesity is defined by a measurement called body mass index. This is a measure of how tall are you versus how much do you weigh. Someone who is fairly short but has a little bit of additional weight will have a high BMI. Likewise, someone who is very tall would have to have a lot of additional weight in order to have the same kind of high BMI. And so body mass index is a way of kind of equilibrating everybody's weight to know what truly defines as obesity. So we define obesity as anybody who has a body mass index of 30 or higher. And if we could get rid of that little blurb down there, I don't know how to do that. The reason that we look at this is that we know that body mass and obesity relate directly to comorbidities and the various health conditions that having excess body weight does. So that's when we talk about comorbidities. These are things like joint disease, bad hips, bad knees, high blood pressure, diabetes. All those things are tied directly into that obesity. Now, when we talk about surgeries, we talk about two different types of surgeries. We talk about restrictive surgeries and we talk about malabsorptive surgeries. And this is what we're doing to try to lose weight and to try to take care of some of those comorbidities. So a restrictive surgery is one that restricts the amount of food that you can consume. It decreases the number of calories that are available to your body in that regard. And so a sleeve gastrectomy, one where we take the stomach and we make it significantly smaller, means that you can't put as much food in that stomach, and that translates to less calories. A malabsorptive procedure is one where your body has less of a chance to digest the food that goes in your mouth. And this is what a gastric bypass procedure does. We'll talk about this in a little bit more. But if you can shorten the amount of intestine that your food is seeing, then that amount of intestine can't absorb quite as much of the calories and the nutrients out of that food. And so it passes through you less digested and less calories there. So
the question, becomes, why do we do this? Why do we worry about it? Why is it a problem? And so obesity has become an epidemic throughout our country. According to the CDC, 42.4% of the population is currently obese. And again, that's based on the body mass index. Anyone over 30 is in the obese category. And so one of the reasons why it's so important is that it's estimated that there's $147 billion spent annually related to taking care of people who are obese. And an obese individual can expect to spend an estimated $1,500 per year more on healthcare.
As we talk about various causes of obesity, there's a whole bunch of stuff that goes into that. It's overly simplistic to think that obesity is just simply eating too much and not exercising enough. That's a very crude way of describing what happens there. So there's a lot of features. Gender makes a difference. Women seem to have, by nature, slightly more body fat than men do. And so that contributes. People's psychosocial factors matter. And it's challenging to maintain ideal body weight if you struggle with issues with depression or struggle with issues of high stress, if there's been any type of remote abuse in the past. We know that there's a genetic tendency toward obesity. It's very rare to find very skinny people in a family and obese individuals in a family. That tends to track together. We see that identical twins tend to maintain similar body mass indexes, and so there's definitely an inherited component that often comes from parents and grandparents. And then there's been a little bit of societal factors that contribute to this. We live in a society where we don't quite have to do as much manual labor as our ancestors used to. We live in a society of conveniences. You don't have to hitch the horses up to go to town and hit the grocery store. And then I'll cover kind of this next little thing. This is what I think is an interesting slide here. This represents the average size of a meal that was consumed. So that first little tiny hamburger is 1955. And when you look at the quantity of food that is consumed in a single setting, you can see that from 1955 to 2006, there's been almost a threefold increase in the size of a meal. And the question is, well, if that keeps going on like that, what's a meal going to look like 20 years from now? And that really plays directly into why excess body obesity and excess body mass index is such a prevalent thing in the United States.
So next we kind of talked about the costs. Why does this happen? The next thing that we'll talk about is individually how that relates to your health, and what untreated obesity can lead to, and especially make worse. One of the endpoints that we often look at is high blood pressure, diabetes, things like that can either become worse or become present because of obesity. And so you can read throughout this slide the multiple different ways that it can affect your health, from diabetes, like I said, to stress incontinence, gout, depression, asthma, high cholesterol, obviously, and can worsen things like COPD, even restrictive lung disease. So
when it comes to addressing some of these things, we take a proactive stance. It's nice to take care of preventing some of these problems before they turn into problems. It's nice to do a weight loss surgery before a knee replacement has to happen, or before a hip replacement has to happen. And it's nice to preserve some of those things. It's nice to take care of that high blood pressure and that diabetes before you have to be on 3 medications for each of those kind of things. So there's a proactive component to that. There's clearly an association between having excess body mass and a range of various cancers. These things have measurable effects on people's health and on lifespan. And it ranges from ovarian to colorectal cancers to liver tumor, and even stomach cancers. So you can make a pretty good argument for doing this kind of stuff.
And just like we talked about in terms of how this relates to your longevity or how long you're able to live with beyond what the average person lives. As your BMI goes up, we can see the percent chance that you will reach the age of 70 goes down accordingly. So BMI of 23 to 25, 77% of men are reaching 70, 88% of women are reaching 70 years of age, obviously. But then as the BMI goes up, 35 to 40, 40 to 50, you can see that kind of dropping precipitously. So we can see that over time, all of these different comorbidities that build up have effects on both your mortality and your quality of life.
We try to present a rosy picture of bariatric surgery, and it's not so much that we are dying to operate on you, but that we believe that the surgery really does provide some pretty tremendous health benefits. So who qualifies? Who does this surgery really apply to? You need to be between the ages 18 and 65. Younger than 18, you need to be at an advanced center. to have that procedure done, and requires a couple of years of close monitoring before you would qualify. Older than age 65, and you start to run into recovery problems after surgery. You need to be young enough to be able to tolerate the surgery and tolerate the significant amount of weight loss that comes with it. And so those are fairly strict criteria. Body mass index needs to be in that range of around 35 to 55, or in females 35 to 60. And that to do body mass indexes beyond that, you need to be at a big hospital for that. You need to have a full care team that's there to take care of you. And so that would be a procedure that would happen, at the University of Utah or LDS Hospital, or up there in St. Luke's and Boise. And so you need to fit that guideline. There are a number of options that are available to you in order of doing bariatric surgery. And what we focus on here is primarily the gastric sleeve procedure. And we're going to talk a little bit more about what this exactly is. But it's not the only one, and for everybody, it's not the best procedure. And so, those people who have a fairly extreme body mass index, they're probably better suited by a duodenal switch or a Roux-en-Y gastric bypass. And we'll talk a little bit more about that. But essentially, it has to do with when you need to lose even more weight, being a little bit more invasive, a little bit more aggressive with your surgery is the right thing to do there. And that's where we would send you to, LDS Hospital or Utah Valley in Provo to have something like that done.
So in terms of kind of going off of the eligibility, what we kind of, in terms of BMI, what we restrict, and leading us into exclusionary criteria. So people, especially at our facility with significant comorbidities, again, would be better served at a larger facility that may need, specific heart care or lung care to be present in the hospital to take care of you post-operatively. Some of these comorbidities, severe congestive heart failure, end-stage renal disease requiring, dialysis, or transplant patients. Smoking, to what extent, I'm not 100% sure. That is a completely exclusionary criteria. Significant psychiatric disease, alcohol or drug addiction, as well as bleeding, clotting disorders.
I think smoking contributes a little bit to the risk of leak after some of these procedures and the risk of those infectious complications. But a relative contraindication there. So there are a lot of options when it comes to weight loss. And most people have already tried many of these, is the short of it. Diet, trying to restrict calories, trying to be very fastidious about what you consume. That's ubiquitous. You see that all over the place. And various exercise regimens with those diets are also widely recommended. It's a challenge. Most of the studies tell us that those do not produce long-term durable results. There are some studies suggesting that if you were to do your diet and exercise under the supervision of a physician, that you might have some better success. And the studies tell us that in the short term, that is true. You do lose weight, you do gain additional health, but it seems that once that supervision stops, then there's a significant backsliding after that. There are some alternatives to surgery, endoscopic procedures. There are ways of putting a camera down your mouth and deploying devices that help you to not absorb the food that you eat. These are still fairly new in the field of bariatric surgery. And the durability of those and the amount of weight loss is still a little bit needs to be proven, but you'll see these things in use if you go to a fairly large center for surgery. They also have kind of their little bits of complication where some of these things can get displaced and moved into the wrong spot or have to be removed and replaced. And then we have the surgical options, which is what we're going to talk about today. And there's reversible surgeries, and then there's non-reversible surgeries. So let's talk about some of those options.
Yeah. So the first one that's kind of fallen out of favor recently is something called the lap band. I'm sure a lot of people have heard about that before. And basically, like we talked about before, restrictive versus malabsorptive, this would be one of the restrictive procedures. Much like when we perform a sleeve gastrectomy, reduce the size of the stomach, that's what the lap band was trying to imitate here, without performing any anatomical changes during surgery. So basically what would happen is the surgeon would slip a band over the stomach, creating and then squeeze it down, creating kind of a little pouch just below the esophagus, where when you would intake food, that area of the stomach would fill up obviously before the lower portion of the stomach. And in that way, your stomach would kind of trick your brain into thinking that you were full when you had really eaten a very small meal, or much smaller meal than you were used to. And in this way, people would lose weight. It's kind of fallen out of favor recently. There are complications associated with this. As you can imagine, it's not the best idea to place a foreign object inside the body, but that is an option that's out there. We don't perform these here, but I think some facilities are still performing this procedure.
I would say it's probably been 10 years or more since that has fallen out of favor. You'll still hear about it. You'll still hear about it putting in a band. And I've sure had to take a lot of these things out, because eventually that band has that potential to erode all the way through the wall of the stomach. And now you've got a hole in your stomach, and that's a terrible problem. And that's why these things have fallen out. The complication rate was just too high. It was a great, initial idea, and it has completely fallen by the wayside. I actually don't think you'll be able to find a bariatric surgeon that does this procedure anymore. So the procedure that we do here and that we'll focus on a lot is this sleeve gastrectomy. And I think a lot of people think about it. They have this image in their mind that you're going to put a sleeve around the stomach and compress the stomach, similar to a lap band. And that's not what we do. What we do is we remove a lot of the excess stomach to create a stomach that's shaped a little bit like a sleeve. And so you can see here what we have is the diagram of the stomach. And then we have a line of staples on the outside. And then we have this excluded portion of the stomach. And so what we do is we take the stomach and we reduce its volume, a solid 70–80%. And what that does is causes you to eat and get full quickly and feel full and feel like you don't need to eat. And that's just after, a small quantity of food. And it's just by simply doing that, that the weight loss is pretty significant after that. So this is a laparoscopic procedure. This is done with cameras rather than done with an open incision. It does require a couple of incisions across the abdomen, on average about 5 or 6 small incisions. Each one is about 1 to 2 centimeters in length. The part of the stomach that we exclude, or that we divide from the main body of the stomach, gets removed and is not there anymore. So there's no connecting it back together again if you wanted to try to reverse this. This is a non-reversible procedure. It's meant to be lifelong, and it's meant to try and control weight for a lifetime. Usually you're spending an overnight in the hospital after a surgery like this, and then as long as things are well the next morning and pain is good and there's no issues with nausea or vomiting, typically you're able to go home. You won't be fully recovered when you go home. There's still a lot of recovery that has to happen. But once we can kind of prove that there haven't been any complications from the surgery, then you're good to go. There's some relative pros and cons, and I'll pass it over to Dr. Porter to go over some of that.
Yeah, so Dr. Guercio went over a lot of these different advantages and disadvantages, but one of the advantages, obviously, there's no rerouting of the intestine. And as you'll see with the upcoming procedures, that is can be problematic at times. And so we see there's no rerouting of the intestine, even though it's a non-reversible procedure. We don't see a lot of the complications that we see with things like Roux-en-Y gastric bypass or duodenal switch. We don't see any of the malabsorption of iron and calcium that we can see with some of the other procedures that are performed. There's less risk of ulceration, especially we look at the area where we connect the intestine back together during procedures like the Roux-en-Y gastric bypass or the duodenal switch. Those areas are highly concerning to get ulcerated at times. We don't see as much internal hernia and bowel obstruction because of the way that we perform the procedure, as well as where the procedure is performed is less of a concern. We do see staple line complications, and that's kind of the main downside to doing these sleeve gastrectomies, and what we as surgeons look out for, probably number one postoperatively. And what can happen is these staple lines, they can break down and leak, and that becomes a big deal in terms of your recovery. There is slightly less weight loss compared to the gastric bypass. We'll kind of go over some of that. And people who have severe reflux disease may need to look for another type of procedure than the sleeve gastrectomy because of how the procedure is performed. Some of the anatomic changes that are made can make you even more susceptible to reflux.
We'll talk for a moment about the gastric bypass here, and this is also a pretty viable option when it comes to weight loss surgery. And we don't perform this procedure here because of its added complexity. This is something that does take a little bit more time to do. So it's a longer procedure in the operating room. And it requires the connection of a couple of different parts back together again. We call that an anastomosis, where you attach the small bowel to the stomach. So if you look in this diagram, what we have is we have the stomach, and we have the large portion of the stomach separated and divided from a small remnant that's attached to the esophagus. I don't know if you can see my pointer here. So this is the stomach pouch that's left behind. And what has happened here is that a loop of small intestine is brought up and attached to that stomach pouch. So the quantity of food that you eat corresponds to the size of this pouch. This pouch is usually around golf ball sized, maybe up to racquetball size. So any meal you eat needs to be within the confines of that size. And that's somewhat true with a sleeve gastrectomy as well. But the difference with this is that there's a bypass of some of the small intestine that happens. So your food travels into the stomach pouch and then immediately enters the small intestine, having skipped several feet of bowel. And when you skip several feet of bowel, you don't absorb the nutrition and the calories from the food that you ate in that skipped portion. And so you get both a restriction on the amount of food that you eat, and then a lack of absorption of calories for that portion of the bowel that's been bypassed. So it's a very good procedure for causing weight loss. And you lose a little bit more weight with the gastric bypass than you do with a sleeve gastrectomy. However, and you know, talking about some of these advantages and disadvantages, the leak rate at those anastomosis is slightly higher. And so that complication of having some leak internally, which is a bad complication, is slightly higher with this. It also, by bypassing a short segment of your intestine, you're not absorbing the vitamins and nutrition in that segment. And so you can run into some issues with iron and calcium absorption. And so we do recommend everybody who gets a gastric bypass that they're on some type of vitamin replacement indefinitely after that procedure. These procedures are also somewhat prone to the development of ulcers. I'll go back here. This remnant pouch of the stomach still produces stomach acid, and that stomach acid is immediately dumped into the small intestine here. This loop of intestine is not real accommodating to having stomach acid put in there. It's not the standard loop that gets stomach acid. And so occasionally, not frequently, but occasionally, a small ulcer will develop there. And that ulcer is certainly much more prominent if there's any type of use of medications that can cause ulcers. These are like NSAID medications, ibuprofen, naproxen, Aleve, Advil. Those things need to be fairly fastidiously avoided when you do a gastric bypass. So this is a reversible procedure. You can reconnect stomach. It's still there. It's not been taken out. But it's difficult to reverse. It requires a lot of surgery to do that stuff. And then this last thing that's worth mentioning is dumping syndrome. And this is a funny thing that happens. You eat food that has a large amount of carbohydrates in it. And that bolus of carbohydrates, as it hits your stomach, sends a really aggressive signal to the rest of your bowels to evacuate. It thinks that it's going to receive this huge meal of carbohydrate that it has to process. And so it says, I got to clear out, I got to make way for these carbohydrates. And so occasionally people who have had a gastric bypass, if they go and have a pasta spaghetti type meal, they can be in the bathroom, you know, half an hour later, having diarrhea. And that's kind of dumping syndrome. We see that with high carbohydrate things and high sugar things. Not super frequent, but it does occur from time to time with that. It's definitely the surgery of choice if you have severe acid reflux, because it removes much of the acid producing stomach that can roll up into your chest. And so if acid reflux is one of the prime issues that you struggle with, it's just terrible, a gastric bypass is probably the better choice versus a sleeve gastrectomy. In both cases, usually acid reflux gets a little better simply because you're taking a lot of weight off the abdomen. And so that will help. But if reflux is killing you, I would recommend the gastric bypass. We've got a third alternative here.
Right. Just to kind of briefly mention this is called the duodenal switch. This is definitely the most technically difficult from, surgeon standpoint, but it also is the most aggressive in terms of patient recovery, patient outcomes, complications. Essentially what this is kind of a combination of the two different procedures. A sleeve gastrectomy is performed. You can see the staple line along the stomach. But then along with that, you have this long segment of intestine that's bypassed, clear down almost towards the colon. So a large length of bowel is bypassed in this procedure. And so you can imagine every complication that you get with gastric bypass is even worse with the duodenal switch in terms of malabsorption, dumping syndrome. All of these things can be even worse with duodenal switch. But the advantages are obviously you lose even more weight. And so people will see 95% here. It says patients losing and maintaining greater than 80% of their excess weight loss. So that's probably the most successful in terms of straight weight loss. The problem is, like I talked about, higher complication rate, higher long-term risk of malabsorption complications, as well as the dumping syndrome that we talked about before.
With the duodenal switch, this is a procedure that usually isn't done first. This isn't the primary procedure that a surgeon is doing. Usually this procedure is done after someone's already had a sleeve procedure. And if for whatever reason there's been a lot of weight regain or not as good a result as was wanted, then the sleeve gastrectomy can be converted to a duodenal switch to get kind of that additional benefit of having had a bypass in addition to the sleeve. So the duodenal switch works great, but it's kind of a backup procedure if you're still having a little bit of trouble with the sleeve gastrectomy. So when we talk about doing bariatric surgery, there's a lot of benefits, but there's also kind of this risk equation that we have to look at. So the biggest risk we worry about is having a little leak, a small amount of stomach acid that escapes that staple line on the edge of the stomach. And again, that's a big problem. It creates a fluid collection, maybe creates an abscess inside. That risk's about 1%. So 1 in 100 people who have a sleeve gastrectomy can look at experiencing something like that. That requires intervention. It requires us to maybe put a drain in there or go back in surgery and make sure that that area is closed. And so occasionally we do go back to the operating room to fix something like that. Occasionally we run into some terrible scar tissue and we can't do the surgery by cameras. It's just not possible. And at that point we have to make an open incision along the stomach and along the edge of the ribs in order to be able to get the procedure done. That definitely extends the recovery time in the hospital, but typically we're still able to get the procedure done in an appropriate fashion. When we do surgery on people who have obesity, there is a slightly just generalized increased risk when exposing those people to anesthesia. There's a little extra weight on the chest, and so breathing is just a little bit harder under general anesthesia. There's a little bit of extra weight on the blood vessels. And so sometimes blood flow slows down in some of those blood vessels. And so, on occasion, someone will get a blood clot during surgery like this, and they'll need to be on a blood thinner afterwards. It's not frequent, but it's something that we know enough about that we often give blood thinners during the operation, and to try to avoid that. These procedures do create a small amount of scar tissue internally, and occasionally there can be problems with bowel obstructions from that scar tissue. That's not super common, and especially with the sleeve gastrectomy, we hardly ever see this complication. This more applies to the gastric bypass. The big complication I think most people worry about is, what about weight regain? We always hear that people had the procedure done and then all of a sudden their weight came back. And the short answer is some amount of weight regain is very common. Significant weight regain to where people get back to where they were before almost never happens. And so there is some amount of permanent weight loss. And the question is how close do you stay to your maximum amount of weight loss? And that usually happens in the first 6 months to where you reach your bottom weight. And it's pretty significant. A lot of people lose 100, 150 pounds pretty quickly in about 6 months. And whether or not you stay there depends a lot on on how you take care of yourself after this procedure. If you stick with appropriate diets and you stick with small, frequent meals, like the sleeve recommends, and the sleeve kind of reinforces you, because if you eat too much, you'll know it very promptly. You've ate too much and you get some pain or you get sick. But if you do that too much, it's possible to stretch that sleeve out a little bit. And so there is some amount of weight regain that happens, and depending on how well you stick to the recommendations, you can keep that weight regain very minimal or to not at all. But even in the setting of weight regain, we never see anybody get back to where they were prior to their gastric bypass or their sleeve gastrectomy procedure. So it does occur. It is a thing. However, it's probably not as severe as some people would make it seem.
So in terms of the pre-surgery requirements, today we're fulfilling one of those, attending the surgical weight loss seminar. And then it kind of depends on what your insurance requires. You know, some people will want to pay up front, which is fine. But, you know, regardless, we have to pass through some of these steps. Obviously, we're going to be doing a supervised weight loss plan. This will be 3 to 6 months, depending on what your insurance requires of you. Throughout this time, this is a medically supervised diet, so you'll be meeting with your physician or dietitian, getting education, physical activity, that kind of thing. One of the other strict requirements is that you pass a psychiatric clearance through one of our licensed providers. They'll go over with you just to make sure that we don't see any of those exclusionary findings, such as severe untreated psychiatric disease. Obviously, we want to deal with those up front before we worry about treating your weight loss surgically. Another upper endoscopy will kind of depend on the situation, you know, when your last one was performed, if you've had one at all. And then we'll talk about a preoperative class at some point, and then depending on your history, comorbidities, there will be some type of preoperative lab workup that we will get. Again, that will be kind of personalized and a case-by-case basis.
So surgery on average, you're looking at about an hour and a half to 2 hours to have a sleeve gastrectomy done. And then kind of immediately after surgery, there's, again, this is a fairly life-changing event. And I think it's life-changing in a good way, in the sense that things really do dramatically change. You do start to lose weight quickly, and to try to minimize the side effects, we try to be careful with how you are for those first couple of weeks. When your stomach is fairly small, it's pretty easy to fill your stomach up with water, and vice versa. It's pretty easy to fill your stomach up with food and not water, and it becomes easy to get dehydrated. And so oftentimes we're recommending that when you eat, you're spreading out your liquid consumption and your food. You're trying not to drink at the same time. This is very different than often what we're told in the past of, you know, drink a whole bunch at meal times and you know, combine that with your eating. And that's not really what we recommend for this kind of stuff. We want you to separate the two. It's a good idea to be carrying a water bottle around for those first couple of weeks, and to be, you know, frequently sipping away at that. Our goal here is to be getting through, you know, somewhere between 60 and 100 ounces of water per day in order to stay hydrated and not to run into troubles along those lines. The idea of 3 square meals a day doesn't work so well in this situation. It's much better, instead of 3 normal meals, it's much better to be doing 4 or 5 or 6 much smaller meals, little snack type things. Again, we're turning the stomach into, you know, golf ball to racquetball size. You know, that's half of a standard hamburger. That's the whole meal. And the nice part of it is that you're not starving with that. 1/2 of a hamburger is sufficient. Now, I would recommend a hamburger for those first 3 weeks. We want things to kind of settle down a little bit. So, you know, 2 to 4 ounces, 4 to 8 tablespoons. It seems like a tiny amount. However, the surgery takes away the hunger pain. of that amount. And so this is where the weight loss comes from. It does take a little while to recover from just the soreness of those incisions. We don't cut any muscle or anything like that, but we do kind of spread them apart a little bit to put our instruments in. And so it's not unreasonable to spend a little bit of time home from work so that you don't have to be up and doing intense physical activity or sweating or doing all this stuff when you should be recovering. And again, that plenty of water is important. We do encourage people to stay active and stay moving around. That helps prevent those problems with blood clots like we talked about.
And just quickly, the last part, we talk about how oftentimes the initial weight loss is fairly dramatic and over a short period of time. But what we want to continue are those healthy lifestyle choices throughout the rest of your life so that you can maintain that weight loss. And I think one of the best ways that you can do that is through these support groups, because over time, Dr. Guercio and I will be able to see you, every so often, but really you're going to need that day-to-day interaction with other people who are going through the same things that you are. And that's where these support groups are very helpful and can really assist you in maintaining those healthy lifestyle choices.